All right, so we're going to finish up our neurology and headache talk. So again, right before spring break, so it's fantastic. I need to go over 45 minutes. You guys got nowhere to be, so it's perfect, right? Okay. Any questions from last time that we talked, or any questions in general? All right, we were talking about anti-epileptics, if you remember. And so we're covering some of the drugs. We talked about benzodiazepines, right? Remember how those work?
By making GABA work better.
They make GABA work better, right? It helps GABA to bind more readily to those receptors. Once GABA binds to that receptor, what happens?
An inhibitor.
Okay, how does it inhibit?
Oh, chlorine.
Yeah, chloride is going to flow through into the neuron. It's going to hyperpolarize it because it makes it more negative, less likely to have action potentials, right? So it's good for not only for treating seizures, but what else are benzos good for? Good for anxiety. What else? Like we mentioned, seizures. What else? It causes amnesia, so maybe you didn't remember that I said seizures the first place, right? Just kidding. We also have like muscle relaxants, right? So they work well as that as well. So if you have like a lot of spasticity issues, you may see benzodiazepines being used for that. Okay. So again, remember those are GABA A channels. GABA Bs we have as well, but those are more for the skeletal muscle relaxants like baclofen and tizanidine and things like that. We covered that briefly in the ortho section. So up next, so other drugs that are going to be affecting the GABA channels include phenobarbital. This falls under the category of what we call our barbiturates, right? So if you ever hear barbiturates or barbs, that's what we're referring to. We have a few different ones here, but the more common one you're going to run into is phenobarbital or luminol is the brand name. More often than not, you're probably going to see this being used more in children, especially with really difficult to treat seizure disorders where they're having like seizures several times a day, and they're very difficult to manage. Also, we like to use this for neonatal seizures as well. So when talking about the benzos, what do we say their main sort of side effects were going to be? Sedation's a big one. Same thing here. In fact, you're going to find that these tend to be a little bit more potent because they don't just help GABA to work better, but they actually directly open those GABA channels, right? They're going to directly allow for that chloride to flow in. So typically, on an equal potent sort of dose there, you're going to find that phenobarb is going to be a little bit more sedating. You're going to see more things like amnesia seen with it, ataxia, lethargy, goes with sedation. The other big thing you can see as well is hypotension, right? So you also see blood pressure that can drop with this. This is one we do therapeutic drug monitoring on, so we do monitor for levels with this one to make sure they stay kind of within a range. But this is one of those drugs you're going to find where the range is, we have like the recommended therapeutic range, but people can live kind of anywhere within that and well beyond that. We have some people, say like a 15 to 30 mic per ml is a good concentration for most patients on phenobarb. All patients that live up in the 50s and the 60s, and they're totally fine. They get very tolerant to the sedation effects, but you can still get some of those good anti-epileptic effects from it, right? So just be aware that, you'll see this more used in children, not so much in adults, because again, sedation makes it really difficult to do things like go to work or go to school and things like that. So that's why we don't like that as a go-to, right? Because again, benzos, when are we using benzos for seizures? For like chronic prevention or more for acute treatment? Acute treatment, right? So again, you don't want anyone for seizures to usually be on benzos on the long term. There's some exceptions to that, like that clobazam drug I mentioned is one you'll see used we see it in some children on it chronically, but again, that's usually when they're on a third or fourth drug on their cocktail, right? So again, sometimes patients are very difficult to manage. They're going to be on a lot of drugs all at the same time. Okay. It's also a C4, so these are also going to be controlled substances. You're still limited on, like, say, a 6-month total duration of that prescription. The sort of restrictions there. As I mentioned, CNS depression is going to be the biggest thing. You can see some of that paradoxical excitation we mentioned, like you can see in children. So just be aware of that. And then we also have some CYP enzyme interactions to worry about as well. This will actually induce 3A4 and 2C9. So again, you got to watch for those drug interactions. Okay. And so, as I mentioned, typically this will be good for patients like neonatal seizures is a good case for this. If they've failed multiple other anti-epileptic drugs, this is a good drug to maybe try. And then certainly if they have refractory status epilepticus. And what do we say status epilepticus is? Yeah, they have continued seizure where they don't return back to their baseline in between, right? They go from that post-ictal period right back into another seizure. And so oftentimes we'll have patients who will get benzos initially. They'll get maybe 2 or 3 doses of benzos. They're still seizing. We'll give them phenytoin, still seizing. We'll give them, and then that's usually when we bust out the phenobarb, right? At least in the children that we manage, that's usually kind of the course that we run there, right? But again, that range, as I mentioned, can vary greatly depending on the patient. I've seen, as I mentioned, patients in the 50s and 60s, and they have no issues with it whatsoever. Okay, up next is a very specialized drug called ethosuximide. This one is primarily just working on the calcium channels. And so because of that, it has no real use for generalized sort of seizures, but for absent seizures, this is the drug of choice. So if you ever have someone who is diagnosed with absent seizures, ethosuximide is a really good one. Valproic acid is also a decent one for that as well because it has some of that calcium channel inhibition, right? Again, these aren't the same calcium channels we see on the heart and on the blood vessels. These are those. You guys remember what type we're talking about? Usually, like for the heart, you think about like L-type calcium channels. These are T-type calcium channels. That's why they have that different activity there. Okay. Again, not useful for all anesthesia types. You're not going to see this used very frequently, but it's good to know. This is like a good board-style question. I say, you have patient diagnosed with Absalon seizures. What's the drug of choice? Ethosuximide every time, right? Some nausea and vomiting, few adverse effects, pretty well tolerated, but again, you're not going to see it too frequently. Next we have gabapentin and pregabalin. Now we've mentioned these before. Anyone remember where we saw these? Neuropathic pain. Yeah, these are actually really good agents for neuropathic pain. You'll see it a lot for like MS. You'll see it for fibromyalgia, postherpetic neuralgias, all the different sort of neuropathic issues. These are working very similar. Although they look like GABA, they don't actually activate the GABA A channels like GABA does. We maybe think that they help with maybe the synthesis of GABA. Maybe they work with some of these calcium channels. Some things to note though are that they are entirely renally eliminated, so you do have to watch for that because you might hold on to too much of the drug. They have poor kidney function. And again, usually these are not good for single line agents for seizure disorder. Usually you're going to be as an adjunct, right? So you're going to be adding it on to your other cocktail. But you may see them used as monotherapy for things like postherpetic neuralgias and other types of neuropathic pains. That's probably far and away we're going to see this used much more frequently there. Biggest side effect you're going to see is just CNS depression, right? These are otherwise very well tolerated for the most part. And then while gabapentin itself is a non-controlled substance, pregabalin is a controlled substance, and being a C5, right? And C5 we said has kind of the lowest risk of abuse potential, but someone probably noted euphoria in one of the clinical trials, and they said, okay, let's just go ahead and make it a C5. I don't know. It's really not that dangerous from an addiction sort of standpoint, because again, a lot of these patients, they're usually going to be on other medications, are much more abuse prone than just pregabalin. But anyway, for fairly good drugs for neuropathic pain, that's where you're going to see it most frequently. Next we have lamotrigine. I'm seeing a lot of patients being put on this as sort of initial first-line therapy for seizure disorder, especially adult patients who are now being diagnosed a little bit later on in life. Mainly because you don't see a ton of sedation with it. Patients are usually still able to operate pretty normally while on lamotrigine. We also saw this elsewhere. What other condition do we see this used for? Bipolar disorder, right? So again, remember a lot of the anti-epileptics, especially sodium channel blockers, tended to have double duty for bipolar disorder as a mood stabilizer plus as an anti-epileptic.
Anything to do with lithium though? Because I don't know, I always thought that it was like a lithium type medication.
Yeah, while they are both mood stabilizers, they are working very differently than one another.
I think I thought the L.
Yeah, sometimes you just run the L's in your mind. Lithium, lamotrigine, lamictal, lithobid, like all those names kind of run together a little bit. And again, that's how we get medication errors, right? Yep. Someone comes in the hospital and say, hey, what are you taking for bipolar disorder? And they say, oh, I take lamictal. And then you go see two other patients and you're trying to remember, what did the patient say they're on? Oh, I think they said they're on lithobid. Okay, let me write that down. Right? That's how errors happen. Very common. So again, that's why we talk about look-alike, sound-alike drugs. Hydroxyzine and hydralazine, they get mixed up all the time. Different types of insulin get mixed up a lot. So you have to be really, really careful with those things, right? Because again, this is like a new language for everyone here, right? So you have to learn to parse out those different syllables and make sure you know, like, if I'm talking about hydralazine, I'm talking about blood pressure management. I'm not talking about allergies, right? So very, very important. It's a very prone sort of error. Anyway, so this one is primarily working to block sodium channels, but it's also helping to block glutamate a little bit, and that's good because glutamate is what? Excitatory, right? So if you block glutamate release, that can help to decrease the excitability as well. So kind of working on from two different mechanisms there. Maybe a little bit of calcium channel inhibition, but those are the main mechanisms. Note as well, though, that if you're adding this onto valproic acid, this is a very important drug interaction. I see a lot of people miss this. You need to drop your dose of lamotrigine by half, essentially, because valproic acid will inhibit its metabolism. And it's not unheard of that you'd add these two drugs together, either as mood stabilizing agents for bipolar disorder that's really difficult to manage, or say, for instance, for a seizure disorder patient, right? Now, the big thing to note here as well, and this is the one thing I want you to take away from this, is that the skin manifestations are the big thing you have to worry about with lamotrigine, right? You have to let them know if you see any rashes starting to develop, any blisters, anything. We talked about a lot of anti-epileptics. It can cause things like Stevens-Johnson syndrome. This is another really big offender here. Like, phenytone's a big offender, but you're starting to see less and less of that being used chronically. However, lamotrigine gets used all the time, right? So let them know, hey, if you start seeing any blisters, if you start to notice that you're starting to get these sores in your mouth, anything like that, they need to discontinue it abruptly. Come to the ER, right? Because again, it could be toxic epidermal necrolysis, could be Stevens-Johnson syndrome. You have to have that monitored early, or at least caught early, so that way you can give them that good supportive care. Okay, otherwise it can be fatal. Those are the big things. Maybe some dizziness, some ataxia, but the skin stuff is a big thing you want to educate on. Okay. Okay, up next we have a something that is relatively new, but starting to become very widely used, at least in the pediatric realm, for seizure management. It's called levateriatam or Keppra. So Kepra's a lot easier to say than levateriatam, so people just call it that. Anyway, so this kind of works via this kind of new novel mechanism. It's working on the synaptic vesicle proteins, SV2A, and basically it prevents certain neurotransmitter releases. So maybe things like glutamate, right? Maybe things like calcium that tend to be more excitable. By inhibiting that, you're going to be able to modulate those neurotransmitters and help to decrease excitability there. So now it's quickly becoming first-line therapies, as I said, especially in pediatrics, where if you have a kid coming in for seizures, we would treat them, say, with a couple of doses of Ativan, lorazepam. If that still hasn't fixed the seizure, then we actually would switch over to Keppra. In days past, we would use phenytoin as kind of your go-to, but now because of issues with administration, we talked about that purple glove syndrome you can get with that. We talked about the kinetics of it being kind of a bear to deal with, the therapeutic drug monitoring. Now Keppra is kind of becoming the first line because it is very, very well tolerated, right? Very little sedation associated with this. You do have to watch renal function, but there's no therapeutic levels we're watching for. You basically can just titrate the drug up to very high doses, and the patients don't really have problems with it. I've seen some patients be, say like a starter dose, for instance, is like 20 milligrams per kilogram per day. I've seen some patients up to 100 milligrams per kilogram per day. So they can go very high doses to get their efficacy there. So nice. The one thing I will note, though, is kind of a unique sort of side effect with this is you can see increased aggression. This is mostly notable in children. That's why they saw that most in the clinical trial. So if you notice you're giving this and the patient seems a little bit more aggressive, maybe they're not playing well with the kids at home or things like that, that could be related back to the Keppra, okay, so some of those mood changes. Next we have peerme or Topamax. Anyone know where else we've seen this? Probably haven't talked about it too much yet. Yeah, you will see it in migraines. This is becoming a popular one for migraine prevention. So we'll talk about that a little bit later in this section here. But it has a lot of mixed activity here. So it can do things like block sodium channels. It can enhance GABA activity. It'll actually antagonize some of these glutamate receptors like the AMPA or the kainate receptors. And so decent as a antiepileptic, usually not first line, usually is an add-on, second or third line sort of agent here. But you are going to see it used for other conditions. So primarily you're going to see it used for things like migraine prophylaxis. You may see it. You can actually have a little bit of weight loss associated with this drug. So you may see that used as an off-label indication very occasionally. So just be aware of that. Relatively well tolerated, few side effects. You do want to note, though, this is a carbonic anhydrase inhibitor. What does that mean? Yeah, you're going to pee out bicarb. Good. And what does that do to the body as far as pH? Good. And what do we talk about as far as that goes with seizure threshold? Yeah, increases it, right? Remember we talked about you can put a patient on a ketogenic diet to make them more acidic, and that makes it more difficult to have a seizure. So maybe this is part of that mechanism there of how this works for seizures. Okay, so just something to think about. Also, because you're doing that, you can also see things like renal calculi that can develop. So just be aware of that. Usually, when you have patients have like a carbonic anhydrase inhibitor on board, and they will start to pee out that bicarb, they get what we call a non-gap acidosis. You guys are familiar with the anion gap? What is that?
Essentially, this is dumbed down version.
I like dumbed down.
If there's an anion gap, it's like you have like a new acid coming into the system.
Okay.
Right, like a salicylate.
Salicylate.
Mm-hmm. That is something new coming into your system. So it's like there's a gap now.
Okay.
I don't know. Is that wrong?
That's pretty all right. Yeah, okay. Absolutely. So how do you calculate the anion gap?
Sodium minus chloride plus bicarb.
Right, so you take your positives minus your negatives, right? So you take your sodium, you subtract chloride, you subtract bicarb from that, and typically 14 plus or minus 2 is what we consider the upper limit of normal, right? So once I start to get above like 16, that's why I start to consider that to be we call it gap acidosis, right? What you end up finding is that with something like carbonic anhydrase inhibitor, you actually get what we call a non-gap acidosis, where because you're peeing out that bicarb, but you're actually holding on a little bit more chloride, that gap actually never forms there. And so because of that, they're still acidotic to some degree. So if you got an ABG, it would show, yeah, they're below 7.35. However, their anion gap would actually be normal. So again, just a little bit of a tangent. You don't necessarily need to know that for the test, but just some things you may find that drugs can actually induce some of these other sort of conditions. So if you hear non-gap acidosis, usually think about things like, if you're peeing out too much bicarb, it could be renal conditions that do that, but it could be drugs as well. Okay. Anyway, just as I said, another tangent. So looking at drug levels for these drugs, not every one of them requires drug monitoring, but you need to know what they mean, right? You need to be able to interpret these levels to say, like, okay, is this too high? Is it too low? But what does that mean for the patient? So, for instance, if I have a level, say a therapeutic range for phenytoin is 10 to 20, and the patient comes back and their level is 22, patient's not having any side effects, they haven't had any seizures for 6 months, what do you want to do with that dose? Don't touch it, right? Again, treat the patient, not the number. However, if I had a patient, say, for instance, they were on valproic acid for their seizures, come back, the level's within the normal range, say it's 75, I'm shooting between 50 and 100, so it comes back at 75. They're not reporting any side effects, but also, what other lab tests would you want to monitor with valproic acid? Not kidney function necessarily, liver function, right, because it's a known hepatotoxin. Well, what happens if that comes back? Again, patients not have any problems with the drug whatsoever, but AST, ALT come back and they're like in the 300s. You might actually take them off altogether, right? Because again, they're showing you that, listen, I'm having this hepatotoxicity in the presence of this drug. So that's in one of those cases. And sometimes students will have trouble with that. When I say stuff like treat the patient, not the number, I tell you, oh, well, the patient's doing fine, but the LFTs are bumped. That's a case where you have to look at the number. That's telling you something. That's telling you damage is happening here, right? You need to correct that. So in those cases there, maybe dropping the dose of valproic acid would be enough to fix that. But again, they're already showing me they're heading in the wrong direction. I would just stop it altogether, right? So little things like that, right? Being able to interpret these levels. If a level comes back too low, what's something you have to consider? I mean, do I need to increase the doses is a question you're ultimately going to ask yourself. But before that, what do you need to figure out? Okay, could there be a drug interactions? Lowering that could be one thing, right? So if I have, an inducer on board that may be dropping the levels down, but what else?
Maybe they're not taking their.
Maybe they're not taking. Maybe compliance is an issue there. Another question to ask is, are they at steady state, right? Remember, if they're steady state, they're going to look falsely low. And so if you check it too early, you're going to falsely decide that I'm going to increase the dose. And then when they actually do get to steady state, they're going to be toxic, right? So again, little things you have to consider. It can be very difficult to interpret these lab values, but again, the more you see it, the more you're going to get very accustomed to it, and you'll have a better kind of intuitive sense on what to do with these values here. Okay, so again, treat the patient, not just the level, but use that level in conjunction with other things that are going on to tell us what do I need to do with this. Okay. And again, if I have a question on a test, I'll make it very obvious. Something either bad's going on or nothing's going on. I'll make it pretty clear cut. I'm not going to have you, need to be practicing for 20 years to make an educated guess on my questions here, right? I'm not here to trick you. Anyway, so as we're talking about adverse effects, just in general for the antiepileptics, CNS depression is the most common thing you're going to run into. And that makes total sense because I'm trying to slow down those neurons from firing because I don't want to have that seizure there. So, of course, you're going to see that happen there. Just like with antiarrhythmics, a lot of them can cause bradycardia because I'm trying to slow down conduction in the heart, right? So all of that makes sense there. Just be aware with something like Keppra, you can't see that increased aggression. So in children, sometimes that did manifest as suicidal attempts, so again, be aware of that. Maybe if they have a history of depression, Keppra is maybe not the best drug for them, right? Things to think about. Lamotrigine and valproic acid tend to be a little bit better from the sedation standpoint, which is why you see a lot of patients either using VPA as first line as a mood stabilizer. You see lamotrigine being used in a lot of adult patients for new onset seizures, things like that. So just something to consider there as well. Okay. The skin manifestations can be very, very bad. So again, a lot of these antiepileptics can cause issues like carbamazepine, ethosuximide, phenobarb, phenytoin, and then the lamotrigine, as I mentioned, is going to be one of the more common ones you think about. And you definitely have to educate on this because again, if they start to be like, oh, I'm just getting this weird rash, and they don't do anything with it, it can develop pretty quickly. And then if they don't get appropriate supportive care in an amount of time, that can be fatal, right? You have to be really careful with this. Okay. You can see some hematologic side effects that come about from these antiepileptics, things like agranulocytosis, aplastic anemia. These are exceedingly rare, but you do want to monitor for these, right? So again, if they say, patient's on something like carbamazepine, they're just, they develop this, kind of odd infection, maybe they get thrush, something like that. You'd be like, hey, what the heck's going on here? Check a CBC. Where all those granulocytes go, right? You have to know that, hey, this could be drug induced, right? It could be something else going on. It could be the medications that are involved with this. So again, that's why it's really important. When you see something that looks kind of abnormal for a patient who's shouldn't be developing one of these kind of blood dyscrasias, look at the medication list because oftentimes you'll find something that could be contributory there. Okay, so again, monitor for things like fever, sore throat, mouth ulcers, things like that could be a sign that their hematologic system is not reproducing appropriately. It could be related to those drugs. As far as hepatitis and hepatic failure, again, valproic acid is probably going to be one of the bigger ones you're going to see as an offender here, but carbamazepine, phenytoin can also do it as well. Definitely for valproic acid, though, you have to monitor LFTs at the baseline, and then usually like at least 6 months out to kind of see where they're at. Now again, with your transaminases being elevated, your ALT and AST, is that actual sign that the liver function has decreased? Not necessarily. It's not, even though we call them liver function tests, it actually doesn't tell you how well the liver is functioning. What's a better sign that I can look for? PT-INR is the biggest thing, right? Because again, that tells me, is the liver actually making clotting factors? If I started to see the LFT or the INR start to go up, so again, for instance, if you had acetaminophen toxicity hurting the liver, that's one thing I'm looking for, right? I'm looking for PT-INR. And it may seem odd, like, why would you order that? Patient's not on an anticoagulant. Well, they may have been in an anticoagulant sort of state because of the damage that this Tylenol is doing to the liver there. So that's a good marker for actual function of the liver. If I start to see that go up, that is a bad sign. You can have patients that have LFTs, ALT, AST that are relatively normal. That's just because they've gotten rid of all those enzymes. They got nothing left to even measure in the blood, and that's an even worse sign, right? So again, things to consider. Anyway, so any questions on the antiepileptics? All right, again, start off with monotherapy for the most part, and then you add on drugs as needed, right? Oftentimes, you will have them have an as-needed drug to use if they develop a seizure. So, like you would give an EpiPen for someone with anaphylactic allergies. You would give someone something like a as-needed diazepam, or usually a benzodiazepine if they have a seizure. Now, again, if someone develops a seizure, are they able to administer the drug themselves? Not typically, right? Maybe if they have some kind of prodromal symptoms, or if they have a therapy dog or something like that can sense them beforehand, maybe they could do it prophylactically, but a lot of times you cannot. But again, know that the benzos are typically good for acute seizure management. A lot of these other drugs are going to be can be used for that, but more often than not, they're used for more chronic management.
But you said Keppra is becoming first line. Is that like first line after benzos, or?
So that would be, again, first line, and again, it depends on your context, right? So again, my mind usually defaults to like the emergency medicine context, right?
Okay.
So normally what I'm thinking is like, okay, well, EMS, already gave 2 doses of Ativan, patient comes in, they're still seizing, we'll give them a 3rd dose usually. If that's not working, then we bump it up to something like Keppra or phenytoin or something like that, right? If I had a patient who maybe had a seizure, maybe they've been discharged from the hospital, and you're looking to start them on something chronically to try to prevent further seizures, that's where something like Keppra can be really good for that, right? I'm not worried about the acute treatment of a seizure. I have time, I can like start them off on a, maybe a lower dose of the Keppra, work them up to it, and see how they respond to it, for sure. Yeah, those are the biggest things to consider. And always ask, especially if you have someone in the ER who's coming in like via EMS, ask what they already received, right? Because oftentimes they'll have gotten a dose of diazepam rectally at home. EMS might have given them a few doses of Ativan. Again, if they've already shown you they're not responding to that, you need to move on to something else. So they've already gotten like 3 doses of benzos and they're still seizing. That's not going to work, right?
Like, I know you talked about like Versed being like intranasal.
Yep.
If we were prescribing like one of the benzos for seizure relief for our patients to use at home, what's kind of one of your favorites?
Right. So traditionally, diazepam was the more common one. We called the Diastat. It was the rectal gel that we administer. It was very expensive as a product goes because it was made specifically for that.
That's not like, it doesn't have to be inserted. It's just kind of like a topical gel.
No, it's like it has to be inserted. So it has like if you look up pictures of Diastat, you'll actually see that it has like an applicator. You have to apply into the rectum essentially, right? So again, that can be really tough, and you have to educate on how to use it first.
It's really hard to do when they're seizing.
It could be, right, but again, if you have a caregiver, so again, you're going to take their pants down, you're going to pull out the drug. It should already be kind of like preloaded to the set dose, based on the pharmacy will do that, whether it be 2.5, 5, 10 milligrams, whatever the case may be, and basically you need to make sure, and again, the person seizing, right, so again, you have to have a clear head to think, okay, what am I going to do next? I have to make sure they lubricate the actual applicator, because if they don't, that could cause damage, right? To lubricate that and then insert it rectally, and then once they put the drug in, then you have to hold their cheek shut. And again, they're moving around on you. It could be a little difficult, right? A little harrowing, right? And it's expensive, and what we found was though is that the intranasal Versed actually works just as well, maybe better in some cases there. So now we're starting to move more towards using that. And so basically, it'd be like if you were prescribing that, it would essentially be say midazolam. Injectable, because you have to know that it's actually the injectable product that we're using, because it doesn't come as an actual nasal spray itself. 2 milligrams intranasal as needed for seizure, greater than 5 minutes or something like that. Usually when you're putting it as like an as needed for seizures, normally you'll say like more than 3 minutes or 5 minutes, whatever the case may be, because sometimes they'll spontaneously resolve on their own. You don't necessarily need to give a dose. It just depends on the patient, right? And usually they'll have to get a nasal atomizer to go along with it, and basically it's a little attachment. And so the thing is, like, the pharmacy will need to know, like, hey, they're going to need supplies in order to draw this up, because again, it's an IV product. They need a syringe and a needle to draw it up. They'll put it on the atomizing device, and they'll just spray that up the nostrils essentially. I have a talk on intranasal drug administration too, so I think that might be posted somewhere. You can look that up. Adam Wood Farm on YouTube. Feel free to subscribe. Smash that like button, as they say. No, I don't get any money off my YouTube channel. So again, it's all just yeah, maybe one day. I did find out there are 17 PA programs either active or in development in Florida. So I'm already doing 2 of them. So I got 15 more to go. Just kidding. Let's keep moving forward. We have Parkinson's disease. Oh my gosh, I'm only 15 slides in. This is terrible. So we got Parkinson's disease next. Well, what is Parkinson's disease? Resting tremors, difficulty initiating movement, bradykinesia, hypokinesia, a decrease in dopamine, right? We're losing our dopaminergic neurons. We need dopamine to cause movement, right? So again, you're going to find actually that a lot of the side effects from our antipsychotic drugs cause a lot of Parkinson-like effects, because what do? They block dopamine activity, right? Absolutely. So good points to know with this is that you're going to find a lot of crossover between our antipsychotic drugs and some of the effects of we're going to see with Parkinson's. Anyway, right, so we know it's a progressive neurodegenerative disorder. Has anyone seen that movie Awakenings? I think it's from like the 80s, had like Robin Williams and Robert De Niro in it. I would recommend watching that if you get a chance to, because it actually is dealing with a lot of Parkinson's patients who basically it's like they're catatonic. They're so progressive. They've lost all this dopamine. They're just basically just sitting in a wheelchair and they just can't move. They have this kind of locked in sort of syndrome. And then it was about the development of using levodopa for the treatment of Parkinson's, and how basically these patients were going from a catatonic state to actually talking, walking, being able to do things, and then eventually how the drug wears out. And so it's a good reminder of how one progressive this disease is and how the management is going to go to where eventually all of our drugs are going to stop working for these patients at a point. Okay, so just something to know. It's kind of a crummy disease, but it is what it is. We'll talk about some ways we can help to mitigate that as best we can. Okay. Anyway, the big cardinal features are tremor, rigidity, hypokinesia, and that postural instability. What were some of the extrapyramidal side effects you saw from our antipsychotic drugs? Tremor, rigidity, hypokinesia, postural. Yeah, right. So again, it's like inducing a drug. It's like a drug-induced Parkinson's when you have those, especially high dopamine receptor blocking drugs like haloperidol, fluphenazine, etc. Right. Anyway, so we know there are, probably a lot of genetic causes to this. We don't know the full reason why this occurs here. There are some drug-induced causes, though, so we'll make note of that. So the atypical and typical antipsychotics can induce Parkinson's-like sort of effects here. Methyl-dopa, which sometimes you'll see used in pregnant patients, which can decrease dopamine secretion, things like that. And then a lot of chemicals can actually do this as well. So if you ever saw someone who has, say, carbon monoxide poisoning, carbon monoxide can actually cause hypoxia in the brain, and that can damage those dopaminergic neurons, and they develop Parkinson's afterwards, right? So again, there's a lot of different reasons why this may actually occur here. Anyway, so the pathophysiology, and again, this gets very, very complicated, so I'm going to try to keep it down to a level to where we understand why the drugs are working the way they are. Again, you talk to someone who deals with Parkinson's patients all day long, they're going to give you, a 3-hour discussion on all the pathophys behind it. I'm not trying to get into that, right? So, but the main thing we want to focus on, we know we have different dopamine pathways, okay? You need dopamine active in order to stimulate the movement pathways, essentially, okay? So we're going to have D1 and D2 receptors that are here. You're going to find that both of these are going to be understimulated because of the fact that you're losing your dopaminergic neurons, right? They're not there to release dopamine anymore, essentially. And the big thing we're focusing on are going to be this nigrostriatal tract here. That's really important for initiating a lot of these movement patterns, right? So, and again, we have things like the dopamine pathway, mesolimbic pathway. This is important for things like that reward pathway we talked about, but mainly we're focusing on the nigrostriatal pathway. Anyway, so what normally happens, and again, I'm not going to get into the nitty-gritty details of this, but essentially what's happening here is that based on the balance between the dopamine 1 and 2 receptor activity here in the striatum, you're going to eventually see that through a complicated network of stimulatory and inhibitory neurons, eventually you're going to get all signals sent to the thalamus here. The thalamus says, okay, you want to initiate a certain movement pattern, and that's going to send a signal to the motor cortex. That can then send down to the spinal cord and then interact with whatever movement, enact whatever movement you want to have happen, okay? That's normally what occurs here. So again, the nigrostriatal tract is going to stimulate the thalamus, to stimulate the motor cortex, and then you move. What happens here when you lose that, and you have this disbalance here where you have less activity of both D1 and D2 receptors, is you're going to find that downstream, you're going to find you have a very strong inhibitory signal being sent to the thalamus, right? There's actually GABA neurons that are going to be overstimulated to inhibit the thalamus. That means it is more difficult to have the signal go from the thalamus to the motor cortex, which makes it more difficult to have that movement pattern, which leads to hypokinesia, bradykinesia, because it's more difficult for them to have movement initiated. Okay? So again, that's why eventually, when this gets shut down to a point where they basically can't initiate any movement, they become catatonic essentially. They can't move at all. Okay? So again, just know that by having a loss of dopamine there, you're having way too much inhibitory signal on the thalamus, and thus you're going to have way too much, too little activity going to the motor cortex. Okay? And so how am I going to fix this problem? I'm going to give more dopamine, right? So again, that's what a lot of our drugs are actually going to be focusing on, is giving them more dopamine activity. Okay. Other things you're going to find, by losing dopamine, you also tend to have more acetylcholine being released, and that leads to a lot of the tremor that we see in those patients. And again, what can you see in patients receiving antipsychotics? You see tremor. A lot of it is due to, and you see dystonias. How do we treat those dystonias? Give them Benadryl, right? Give them an anticholinergic. So also here, you're going to find that our anticholinergics are going to be useful to block the activity of this acetylcholine, and that will help with the tremor. Okay, so we'll talk about different ways to treat these patients here, but you'll see that there's a role here for the anticholinergics as well. Okay. So anyway, so normally going through dopamine metabolism, and again, I'm not going to get into the super nitty-gritty here, but the things I want you to focus on are two main enzymes. Okay. So one, we're going to have things like some precursors of dopamine coming in, including things like L-tyrosine, L-dopa, levodopa. That's going to be an important drug portion we're going to talk about in just a few minutes here. Now, the two enzymes I'm really focusing on here are going to be Compte, which stands for catecholamine O-methyltransferase, is going to be responsible for metabolizing L-dopa. And then we're also going to find there's an enzyme here called monoamine oxidase. We talked about this already in terms of what? What disease state? Depression, right? Because monoamine oxidase is not only responsible for metabolizing dopamine, but also norepinephrine, also serotonin. This specifically is monoamine oxidase B, right? So it's a little bit more specific for dopamine. So that's one thing I want you to note there. It's not just a non-specific monoamine oxidase, A or B. It's just going to be B here we're focusing on, okay? That is also responsible for metabolizing dopamine. Normally, if dopamine, once it goes through this pathway here, it gets formed, it will get put into a vesicle where it can be released and then activate either those D1 or D2 receptors, okay? But if I lose this neuron, I have less dopamine there, I'm not going to be able to stimulate that pathway, right? Now, what would happen, say, for instance, if I were to inhibit the activity of Compte? I'd have more L-dopa, which could eventually turn into dopamine. L-dopa gets converted, as you can see right here, into dopamine. So if I inhibit Compte, I have more dopamine. That fixes my problem, right? What would happen if I were to inhibit the activity of monoamine oxidase B? I'd have more dopamine. That fixes my problem, right? So we're already going to see there's different pathways here. We can either supply more precursor and give the patient more L-dopa to get turned into dopamine, or I could prevent the breakdown of some of the products here. Okay, so different ways to attack the same problem to ultimately get more dopamine, right? More dopamine is being produced or being not being metabolized, more of it is able to be released there. Okay, these are important strategies we're going to be focusing on. Now, again, as I mentioned, the cardinal features there are kind of those four things: hypokinesia, resting tremor, postural instability, etc. Right? But of course, there's a lot of other issues here as well. They lose a lot the ability to do their activities of daily living as it gets more progressive, right? So they have a lot of dysphagia. So you can have things like microaspirations. It can lead to things like pneumonias, right? So again, you know, all these kind of things that are going to be developing here. So again, it can be very, very debilitating for them. So oftentimes leads to a lot of need for things like home health care or putting into an assisted living facility. And we know things typically go downhill once they're in that sort of setting there, right? Anyway, other autonomic things you see here include things like incontinence and constipation can develop, you know, orthostasis, sexual dysfunction, all kinds of different problems here. Again, I'm not going to get fully into the details, but you'll be able to recognize a Parkinson's patient when you see one based off of a lot of these things that they will develop. Anyway, how do you diagnose Parkinson's? Based on symptoms?
Brain biopsy.
Yeah, so you do a brain biopsy, but
Yeah, measuring
not usually preferred, right? Say, hey, buddy, I'm going to give you a piece of my mind. You want to do that, right? But you could also do something like, well, what if I were to give them dopamine and it fixes the problem, right? Just like I can tell if someone's overdosed on opioids by giving them the antagonist. That gives me my answer right there. I don't need a lab test. I just give them Narcan. If they wake up, guess what? It's an opioid. Just here, if I give them dopamine and it fixes the problem, guess what? It's probably Parkinson's. They have a lack of that dopamine. Okay. So again, yeah, to get the absolute confirmatory diagnosis, you need to, you know, usually after autopsy or during autopsy. We don't want to do that for our patients. We like to treat them a little bit before then, at that point, right? Anyway, So our goals here, one, we like to try to reverse any kind of functional disability they may have already developed. And again, it's nice if we can get these patients early on to treat, but again, it's very difficult. There's no lab test you can do to say, hey, you have Parkinson's, you're going to develop this in 20 years, let's go ahead and start treating you now. Oftentimes, the patients are going to already be manifesting these symptoms. We want to reverse those if we can, and then hopefully try to prevent further degradation. We're going to try to keep those dopaminergic neurons working as best as they can for as long as possible, because again, we know they're going to burn themselves out eventually, so we want to keep them around as best we can. Anyway, so what are our options here? We have non-pharmacologic therapy for sure. We have things like speech therapy, exercise, even certain surgical procedures can be used here. Deep brain stimulation, which hopefully I provide to you guys every single Friday, right? Maybe not. That's okay. But we're going to focus mainly on the pharmacology here, right? Because this is the mainstay of therapy is going to be the pharmacologic stuff. We'll talk about the uncomplicated Parkinson's treatment versus the late stage treatment here. One caveat is that everyone's going to end up on levodopa carbidopa eventually, but we're trying to hold off on that as best we can. So that's one of the main kind of the big things to focus on is like try to hold off on levodopa carbidopa as long as you can until you really have to have it, and then because again once patients are on that, they're going to be on it for probably the rest of their lives essentially. Huh? We'll talk about what happens. Yeah. Just you wait. That's it. Just hanging on the edge of your seat here. That's all you're gonna need, right? Pay for the whole seat. We'll need the edge of it. Just you wait. So some of the things we can use for early uncomplicated Parkinson's includes things that we can use as neuroprotection. That sounds like a pretty good thing, right? Just like we talked about the room drugs, we talked about things that are disease modifying. These help to slow down that progression a little bit. These are going to be our monoamine oxidase B inhibitors and our dopamine agonist. So again, I don't even have to replace the dopamine they're not producing. I can actually give them something that directly agonizes receptors, and that can help too. Okay, we'll look at things for symptomatic management. And you'll see some of these are pulling double duty, like the monoamine oxidase B inhibitors are good for symptoms and for that neuroprotection. And we'll also look at some of our dopamine precursors, anticholinergics, all of this stuff we're going to look at for the early treatment for Parkinson's. So, as far as neuroprotection goes, we have our dopamine agonists. These are good because one thing you're going to find is that, especially patients who are on levodopa, they tend to get more sensitive to the side effects of the drug the longer they're on it, and so they can develop things like dyskinesias after, say, just a few years on there. By giving them dopamine agonists instead early on, this can help to hopefully stave that off and hopefully delay how long it is until they actually need levodopa therapy, as we'll see. We'll talk more about that later. But the other big thing is going to be the monoamine oxidase B inhibitors. Now, what do we see monoamine oxidase B did in that dopaminergic neuron? Well, yes, yeah, we see that with like a antidepressant, but what did it do in that neuron we were looking at before?
It created something.
It metabolized dopamine, right? So it actually broke down dopamine into an inactive product here. Okay. Now what you're going to find is that when you break down dopamine like that, you can actually generate what we call free radicals. Know what free radicals are?
Yeah.
Reactive oxygen species, right? That free electron, and they just go and they start to bind up proteins and destroy them and all kind of good stuff. Well, what do you think it does to that neuron? Eventually leads to its death, right? It eventually leads to apoptosis for that neuron. So what we can do is by inhibiting monoamine oxidase B, you're preventing more of those free radicals from being formed. Hopefully you prevent and decrease that oxidative stress that you're putting that neuron under. And so that is thought to be neuroprotective. Now, do I have any big study that says absolutely this is going to help fix your patient, prevent them from getting worsened symptoms for X many years? No, I don't have that. But theoretically, this makes sense, and it will help to manage some of the symptoms they're having as well, and so that's why we like to use it. So if you imagine here you have dopamine getting broken down to monoamine oxidase B, you have this metabolite, but also what do you notice here? Hydrogen peroxide, right? What happens when you put hydrogen peroxide on a wound? Bubbles up, and yeah, it's always very reactive, right? So again, same thing happened here. You develop these free radicals, and that damages that neuron. That's that oxidative stress we talk about there. Okay. So again, by blocking this, one, you fix some of the symptoms they're having because they have more dopamine available, and then two, you decrease the oxidative stress, and hopefully you keep that neuron around for longer. Okay. Yes, ma'am.
If somebody could we take these inhibitors to kind of prevent Parkinson's symptoms?
You could, but you have a lot of side effects associated with it, right?
Well,
I don't know if you get any benefit.
I don't know, maybe kind of high suspicion.
High risk history in your family or something like that. Yeah, I don't know that anyone's made those recommendations specifically, but who could say?
Do you think it can induce schizophrenia in a normal person?
Could it induce schizophrenia in a normal person? Not that I'm aware of. But what are some of the things we see with the monoamine oxidase inhibitors, especially like with you had too much tyramine, you had too much red wine, and the hypertension, but also a lot of CNS excitation. You can see seizures, hallucinations. I mean, maybe it could look like something like psychosis, right? Who could say? I wouldn't recommend it though. So may say for the Parkinson's patients. Anyway, So a couple of different agents we have here. We have things like selegiline and rasagiline. Both of these are available as monoamine oxidase B inhibitors. Again, they have been found to delay the need for levodopa in some of the smaller studies they've done there. But again, eventually it will lose efficacy. As we're going to find with all these agents here, they eventually will lose efficacy. One thing to note, though, is that selegiline actually gets metabolized to L-methamphetamine. What do you think that shows up as on a drug screen? As amphetamines, right? So again, you will have patients who actually test positive for this. So, you have like little old grandpa coming in with Parkinson's disease, and for some reason you get a urine drug screen, shows up positive for meth, and you're like, Grandpa, what have you been doing? Nothing. He's just taking his Parkinson's drugs, right? So he's just on selegiline. One big thing that you won't see is with that is going to be rasagiline. That doesn't have the same metabolite, so that one would not show positive there. But it's kind of a unique little thing. And again, anytime you do your drug screen and you see something show positive or negative, always take it with a big, giant grain of salt, right? Know what your test is actually testing for, because you don't want to accidentally diagnose somebody as saying like, well, obviously you've been abusing amphetamines, when they're like, I'm in the nursing home. Where am I going to get amphetamines from? Or maybe they are abusing amphetamines. Who could say, right? Anyway, but other big things you're going to see with this, you can see things like insomnia, right? Because again, not only are they going to be affecting dopamine, but they can affect things like norepinephrine. They can affect things like serotonin. So you're going to see some side effects associated with this. Things like hallucinations, things like orthostatic hypotension, right? Again, these are typically older patients. They're usually going to have not as good a hemodynamic reserve as some of your younger ones, so that orthostatic hypotension can be a big deal, lead to falls, lead to fractures, etc. Okay, so just be aware of that. And again, these can be a risk for serotonin syndrome. So if you're treating them for depression as well, that's something you have to consider, right? By mixing these two drugs together, am I going to get too much serotonergic toxicity? All right, think about that. So again, in mild cases of Parkinson's disease, you can use this as monotherapy, just starting out. However, be careful when you're mixing these other drugs. So as I mentioned, things like tramadol, things like methadone that block some norepinephrine reuptake, right? Things like some pathomimetics like amphetamines, things like St. John's wort, things like certain anesthetics in surgery. These are all going to be things that cause you to have a risk for a serotonin syndrome. You got to be really careful with that. So always double check your interactions beforehand.
Is that the one where you eat like the bougie foods?
Yeah, potentially you could have a little bit of a tyramine reaction here as well. Yeah, exactly. So again, thank you for giving that segue right to the next slide. Fantastic. Yes. Right. So again, those are the foods you have to be really careful of, because that increased tyramine will then eventually get turned into things like dopamine and norepinephrine and serotonin, and then not be able to be broken down. So that's where monoamine oxidase B is going to be playing a big role there. Now, this isn't going to be as dramatic of an effect as you would see with a non-selective inhibitor like phenelzine. But again, this is probably the one time you're going to run into these interactions, because you're more likely to see someone on selegiline for Parkinson's than you ever are to see someone on, say, Nardil for depression, right? Because we don't ever really use those drugs anymore. So just something to keep in mind. Anyway, some other symptomatic treatment we can do include our anticholinergics. These are going to be good for that resting tremor, but this is really the only symptoms that are going to be useful for. So if you have a patient who's not really developing into hypokinesia yet, but they have that resting tremor, it's pretty difficult for them to do things like have fine hand control. Anticholinergics can be really useful for that, and you've already seen these because there's the same ones that we'd use to treat acute dystonias from an antipsychotic: trihexyphenidyl, benztropine, diphenhydramine. Any of these are going to be fine. But what are the big side effects you worry about with these anticholinergics? Yep. So okay, I have all those antimuscarinic effects. Sedation is a big thing, right? Think about, these are not great drugs for older patients, because again, it's going to make them a little more loopy. So you got to be aware of that, right? So again, is the patient's dementia getting worse? Is it because I gave them an anticholinergic? Is it Parkinson's? Again, it's difficult to determine which one's the chicken or the egg in those situations there, right? But again, same effects as what we saw with the antipsychotics. We already know a lot about those. Another one we have here is called amantadine or Simitrel. This one's kind of interesting because it helps to increase release of dopamine, but it also has some NMDA antagonism effects, so it kind of blocks glutamate a little bit. And so we have found some success in using this for early onset or more mild cases of Parkinson's disease, either by itself or in combination with some of these other drugs here, and may actually help and be useful for helping to decrease some of the dyskinesias you see with levodopa use, and that's usually a chronic problem you see with that. But just know you can see dizziness, anxiety, insomnia, some of it related back to its kind of multi sort of mechanisms there you see there at the top. And again, anticholinergic effects will be happening with this as well, so just be aware of that. I have seen amantadine used in some cases as an off-label for patients who, say for instance, they're in the ICU for a really long period of time. They've been intubated and sedated for really long periods of time, and now they're ready to come off of all that sedation, but they're just not waking up. We've actually been able to use this to kind of help people to start kind of kind of get the brain going again and have help them wake up and kind of return to consciousness. So sometimes you'll see that used in the ICU. But anyway. So an alternative we could use as well would be a dopamine agonist. So we're basically replacing, instead of giving them something that turns into dopamine, we'll just replace something that can actually interact with those receptors directly, right? And so we're going to find that we have both ergot and non-ergot derivatives. Anyone know what ergot is? It's not the same as an EGOT. You guys know what EGOT is? EGOT's like when you get an Emmy, a Grammy, an Oscar, and a Tony, right? EGOT, yeah, that's EGOT. Ergot is different, right? Ergot is actually a fungus. Grows on you after a while, right? Anyway, yeah, so ergot actually is this fungus. You guys ever heard of St. Anthony's fire? This is like one of my favorite. What is that? Not St. Elmo's fire. It's St. Anthony's fire. This is different, right? St. Elmo's fire is a movie in the 80s. St. Anthony's fire is this thing where basically these again, this is back like in olden times, right? It's probably back like in Middle Ages sort of thing, where of course anytime you had any kind of health malady, what was usually the cause of it? It was the devil, right? So basically what they found was, they didn't know anything back in the day, right? So they assumed it was probably some sort of, affliction from Satan or one of his cohorts. Anyway, so what they found is that they were ingesting this bread. And this bread was actually, it was rye they were ingesting, but it was infected with this fungus. It was the ergot fungus. And so what they found was when they were ingesting this stuff, they were getting this like burning sensation in their hands and their toes. And it felt like, basically what was happening, they're getting this really severe vasoconstriction that was occurring here. The vasoconstriction was leading to a lot of pain, a lot of heat they were feeling, so it felt like fire, right, in their extremities, and eventually could lead to gangrene developing. People are dying from this. And so what they said was, well, I got to get rid of this affliction. So they said, I'm going to go on a pilgrimage. I'm going to go pray at St. Anthony's Cathedral. So as they were going away and going on pilgrimage, guess what? They were getting away from the infected bread. All of a sudden, they got better by the time they were there, and they said, well, thank the Lord, I'm cured. So again, just go to show you. So they call it St. Anthony's fire was related back to that. And basically this ergot fungus causing severe vasoconstriction. So we have ergot derivatives. They're based off of that fungus. And this is going to be important when we talk about migraine treatment a little bit later. We have non-ergot derivatives as well. Okay, and that will go into the side effects. And I mentioned that story because I want you to think about those side effects that occur there because they can happen when these patients receiving these drugs anyway. Okay, that'll be important in a few minutes. Anyway, they typically find that these can be used as first-line therapy early on. But they typically will lose efficacy pretty quickly there, and they will not be as effective as using levodopa, carbidopa later on. So just know that. And again, you're going to find pretty similar side effects as like the monoamine oxidase B inhibitor, just in terms of the fact you have more dopamine activity. So this can include things like hallucinations and confusion. The orthostatic hypotension is a big thing. Peripheral edema can develop here, so just be aware of those. In some rare cases, you can see, especially with the ergot derivatives, you're going to find it can cause things like valve regurgitations or retroperitoneal fibrosis. So again, there's some more serious things that can happen and more chronic use for the ergot derivatives. Punding, it's kind of a difficult. I'm trying to think of a good way to. Huh? It has nothing to do with puns, unfortunately. Otherwise, I'd probably be developing punding most of the time. I think it has to do with something to do with like kind of the shuffling the gait, like kind of like small movements they're making because it's difficult to initiate this thing. So something that can be induced by some of these dopamine agonists. I could be wrong though. So if you Google it in the meantime. Yeah. So it's.
Watches, picking and stuff.
Okay. Yeah. So things like that. So.
Lining up pebbles, rocks, it sounds kind of.
Or small objects.
Oh, that's right. Yeah, they do like the line up the stuff as well. Yeah. So it's an odd sort of thing. Again, probably not going to come up on your boards anytime soon. That's a fun word to say. Anyway. Yeah. So bromocriptine is the main ergot derivative you're going to see used here. And again, you can see that fungus growing on the rye there. That was getting incorporated into the bread, causing that St. Anthony's fire. Some of the non-ergot derivatives we have include peermepexole, ropenolol, and rotigotine. The last one there being a transdermal product, which is good, especially if they're having kind of cognitive issues, and compliance is going to be an issue for them, something to consider. And then we'll also have a drug called apomorphine, which is actually going to be a direct dopamine agonist. It's actually a derivative of morphine, but doesn't interact with opioid receptors, so you don't really see any of that analgesia or euphoria from it. But oftentimes we'll actually use it for diagnosis. If you had a patient who you're concerned of having Parkinson's, they're having some of the symptoms we weren't really sure, you can give apomorphine as a dopamine agonist, and if they get better, then you fix the issue, right? You talked about myasthenia gravis ever before? They're just like a tensilon test. If you give them a tensilon test, you give it to them, and you help to give them more acetylcholine, and it fixes their problem. That's kind of similar sort of provocative testing we're doing here, right? So again, don't have a lab test to confirm our diagnosis, but we can use a drug in order to help get the diagnosis, essentially. All right. We're going to continue on. Any questions from the first half? Besides, can you stop early so we can go to spring break? The answer is no. Just FYI, for the prescription assignment, these are inpatient orders you're writing, right? It's like post-op orders. So you need to use that second sheet that are like made for hospital orders, okay? So this is not going to be outpatient scripts you're writing for maintenance fluids IV. That doesn't make sense, right? So you got to use the actual inpatient order form, okay? So make sure everyone's clear on that one. All right, so we're talking about levodopa, carbidopa now, right? So again, what does this drug do? Basically, levodopa is a precursor to dopamine, right? So they're lacking dopamine, we replace it with a precursor that gets converted over via Compte and monoamine oxidase B and all that good stuff, okay? Now, note, why can't I just give levodopa by itself? Anyone know? It gets metabolized in the peripheral circulation. It gets converted to dopamine, but if it doesn't make it to the brain, it's not really doing me any good there, right? So by using carbidopa, it actually will inhibit this L-amino acid decarboxylase, or this enzyme that basically will metabolize levodopa, and it doesn't cross the blood-brain barrier. So carbidopa will just work peripherally and will allow the levodopa to get into the brain, where it can then eventually get uptaken into those neurons, turn into dopamine, and then be released and cause movement, essentially. And so the brand name here is Cinemet. If you ever see that, it's always the combination. You'll always give these two together. You will not find levodopa by itself, okay? Just know you always see a combination there. So just know that the kinetics here are pretty variable. So again, this levodopa is basically an amino acid, right? So you're going to find that it needs to, its kinetics can be pretty variable. So one of the things that can affect that is going to be the actual transport through the GI tract. So for instance, if you have a really high protein meal with a lot of amino acids in it, it can get basically saturated to where you can't absorb your levodopa very well. So one of the things you're going to find that you may try to do things like scheduling the doses out to where a patient may be taking it, say, an hour before a meal, or they maybe focus all their protein onto one meal out of the day, and they have relatively protein-free meals the rest of the time. These are all things that can help with that, right? And you're going to find that the half-life does get extended out when you have things like carbidopa on board. It's going to be longer because it doesn't get metabolized, gets up into the brain, and they can be even longer than that if you were to add on a Compte inhibitor. And we'll talk about those in just a few minutes here. Okay. Anyway, so typically this can be used as initial therapy for more moderate to severe cases of PD, but we normally will use this after more, say, less effective treatments like a monoamine oxidase B inhibitor, or if we have something like a bromocriptine on board, we'll wait till those fail and then switch over to levodopa, carbidopa. Because usually once patients get on this, they're going to be on it for the rest of their lives, typically. Okay, and so I like to hold off on that as best we can there. But it is the most effective treatment for the actual symptoms of Parkinson's disease. Does it actually do anything as far as the progression of disease? No, if anything, it could accelerate it potentially because you have some of it being broken down into dopamine, and dopamine gets metabolized into those free radicals, right? Partially. If you go back to that neuron, you see that. That's why we like the monoamine oxidase B inhibitors, because it actually was neuroprotective. By giving more of the precursor, you get more metabolites, you get more oxidative stress. So that's why we like to hold off on this as best we can. And again, the side effects are going to be very similar to what we saw with the monoamine oxidase B inhibitors. You're going to see hallucinations, somnolence, orthostatic hypotension, depression can be worse in here. So again, not without its own side effects, so just note that. Typically, you're going to find that we're dosing it based off of the levodopa component there. There's usually kind of a max of the carbidopa you're going to end up getting in this. And you're going to find that the dosing can be pretty variable. Some people are going to get lower doses more frequently. Some people are going to get bigger doses less frequently. We have controlled release preparations. That way they take it less often throughout the day. And it can all be dependent on how the patient's responding to it. We'll talk about some of the levels a little bit later as far as like, wearing off effects and things like that. But just know there are different forms that are out there. Now, why do you think an oral disintegrating tablet could be useful for these patients? Yeah, they get dysphagia, right? So again, they can have a hard time swallowing. So you need to have something that can be useful for patients who might have a hard time swallowing. Some patients will actually have a duodenal infusion they'll be running. That way they get directly administration of the levodopa directly to the duodenum, and that way it can be absorbed that much more easily, right? So again, sometimes we have to get around the disease process itself just to get the drug administered to the patient. So again, a lot of people will not use this at first line because you want to hopefully use something that will hopefully slow down progression over time. So that's why we like things like the monoamine oxidase B inhibitors, like selegiline or resegiline in those cases there. And so some people feel that by using a dopamine agonist or monoamine oxidase B, you're going to hopefully delay the period of time before you need levodopa. Okay, that's the main goal there. Now you also have Compte inhibitors. So this is catecholamine O-methyltransferase. This is another enzyme that was responsible for metabolizing some of the precursors there before you get to dopamine. And so basically what this actually does, will inhibit the breakdown of levodopa to allow for that dose to be more effective, essentially, right? You have more of it available to turn into dopamine there. And so typically you would not use this by itself. You'd only use this in conjunction with levodopa, because that's mainly what's going to be affecting there. Okay. And also you're going to have to reduce your dose of levodopa if you add this on, because again, it's going to be that much more effective. You don't want to see a lot of the side effects there. Of course, a lot of the side effects are going to be related back to the activity of more dopamine. So a lot of side effects are all the same: the orthostatic hypotension, hallucinations, insomnia, things like that. Also note as well that things you can see include some changes in the urine color. So you can see some discoloration there, brown, sort of orangish color. And again, when you think brown urine, what do you think about? The rhabdomyolysis. So you don't need to let them know, hey, you may see this change. It's just related to the drug itself. The two we have here include tolcapone and entacapone. Tolcapone you don't really use all that much often because it's very hepatotoxic. More often than not, it's going to be entacapone we're going to be using. And actually, there's a combination drug where you get all three, entacapone, carbidopa, and levodopa all in the same drug, which is, again, good, because what does that do for our compliance? It increases, right? So if you can decrease the pill burden the patient's having to take, especially if they're having any kind of cognitive issues where maybe they're not thinking about it or they're forgetful, this can be useful in helping to increase that compliance there. So how would we actually manage these patients, right? So how do we actually use these drugs for managing Parkinson's? So, okay, let's say we have our diagnosis first, right? So we're going to figure out, one, what are the primary symptoms we're actually dealing with here, okay? And so part of it could be like, well, are they just having, tremors? Are they just having, what if they're not really having much symptoms at all? Well, if they're not really having much impairment, you can actually start them off on rasagiline, which we said, what type of drug was that? Monoamine oxidase B inhibitor. And again, we saw that was neuroprotective. So that's a good drug to start them out with. So hopefully it'll help to delay progression as long as we can. Okay, that makes sense. Well, what if they're having tremor? Benadryl or some kind of anticholinergic is going to be our go-to drug. Now, one thing to know, you got to be careful with older patients, right? If they're over 65, they actually may not recommend using that initially. They may recommend bypassing your anticholinergics and moving over to something like Sinemet. However, if they're less than 65, that's where you can consider something like trihexyphenidyl, benztropine, diphenhydramine. Any of those are going to be totally fine.
Is that only because of sedation effect?
Yeah, because again, we talk about that Beers list when we get into the Jerry section later on. We're talking about the meds that you don't want to administer to older patients because one, it's going to change their cognition, alter mental status, lead to falls, orthostatic hypotension. There's a kind of a common trend you're going to see with these medications that they're really predisposing them to having a lot of these bad outcomes, essentially. Yes, that's why we don't like it in those older patients. And so again, if that's not working, then again, what does it ultimately always go down to? Levodopa, carbidopa. Always goes back to that, essentially, right? If they're having more bradykinesia, rigidity, maybe not so much of the resting tremor, what can you go with? Well, if they're less than 65, maybe a dopamine agonist, maybe bromocriptine or ropinirole or something like that. And then again, if that doesn't work, Sinemet, right? All goes back to Sinemet. Looking at the postural stability, this is where things like, certainly physical therapy can be very helpful with this. But again, dopamine agonists can be good, or if they're older, go with Sinemet, right? So, and typically what you're going to find is that early on, you're going to start off with this monotherapy. So I can start off with trihexyphenidyl or start off with rasagiline. That's going to do me fine for a while. And eventually you're going to use polytherapy. So you may add on, say, monoamine oxidase B inhibitor plus Sinemet, or I might use, say, trihexyphenidyl plus rasagiline or something like that. And then eventually it's all going to go back to monotherapy, with the late stages primarily just being Sinemet they're going to be receiving. Maybe you're adding on a Compte inhibitor with that, but generally it's going to be Sinemet by itself. Okay. And we call this the levodopa honeymoon. This is where basically when you first initiate levodopa, patient's going to feel a heck of a lot better, right? Because again, they have this new kind of jolt of dopamine hitting their system, and so their symptoms are going to get much better. They feel much better. But again, that neurodegeneration is still occurring over time. So they'll feel a lot better, and they call it the honeymoon period. And then eventually it's going to get into these late stages here of the monotherapy with just Sinemet by itself. Because again, it's going to lose effect over time. Because again, once you don't have those neurons there, you can give them levodopa all day, but if it can't convert it into dopamine to use, then it's not going to do anything, right? So again, often this is a terminal sort of condition. So what do we need to monitor? So looking at things like, drug administration times, looking at how we time drug administration along with things like the food. So like when are they getting their protein intake versus when are they taking their Sinemet? Oftentimes these regimens can be pretty complicated from a dosing standpoint, from a scheduling standpoint, so monitor for those. And then again, we're looking for adverse effects. We're looking for things like non-adherence. Why are they non-adherent? Is it because they're forgetful and they don't think about taking it, or is it because of side effects that are occurring here, right? And then you can assess their function, right? Assess what they're able to do or not do based off of how the symptoms are progressing. Any questions on Parkinson's? Okay, moving on. Next, we have Alzheimer's disease. Okay, now you're going to find there's not a whole lot of drug therapy we can do for this. Unfortunately, this is another neurodegenerative disease, so there's not a whole lot we can do for it. Basically, we can try to stave off progression as long as we can, but eventually it's going to be one of those things where not a whole lot's going to help our patients here. But basically, what we think is happening with this disease state is we're still having a loss of this neuronal function, but the primary neurotransmitter we're going to focus on here is not dopamine, but does anyone know? Acetylcholine is going to be the main thing we're focusing on here, okay? And so we're going to find that by losing some of these hippocampal and cortical neurons, we're going to be having this impaired memory and cognition, right? And again, as it gets more progressive, they're going to be, not remembering who their family is. They're not going to be able to take care of themselves, become incontinent. That's usually what ends up in the nursing home. And I will say that my grandparents, when my grandfather passed away, certainly my grandma, usually when you have patients who are together for like 60 plus some odd years, once one goes, the other one tends to go downhill pretty quick. Same thing happened with her. Alzheimer's kicked in, and it would just progress super, super fast. And eventually, she was in a nursing home, and that was it. So it's one of those things where we can try to stave that off as best we can with some of our drug therapy. It's going to be helpful, but ultimately it's going to be ultimately ineffective in the long run. So just something to note with that. Anyway, so what are some of the things we see with the pathophysiology? Again, these are oftentimes going to be postmortem findings you're going to see there. So again, we don't do any kind of brain biopsies beforehand to see what they are, if they have Alzheimer's or not. Usually you can tell based off symptoms, essentially. But looking at healthy neurons versus some of these neurofibrillary tangles they get here, they get these amyloid plaques that will form here, showing they're having some sort of neuronal degeneration, probably some inflammation developing there, causing them to have some degree of the immune system coming in to kind of attack and try to get rid of those dead cells there, and that's where you see these plaques actually start to form. So our goals, though, are what we're going to shoot for: try to treat some of the cognitive difficulties, try to improve their memory, improve their ability to perform activities of daily living as best they can. But again, there's no way to cure it. There's no way necessarily to prolong life with these patients, or really slow or reverse the condition. Right? Once those neurons are gone, they're gone essentially. So there's kind of two main ways we're going to focus on this. We can either look at it from the acetylcholine standpoint, or we can look at it from the glutamate standpoint. We're going to focus on the cholinergic pathway first. And so basically what we're seeing is that with these patients, we know they're losing cholinergic neurons. So how can we fix that? We can give them more acetylcholine, right? Well, how do we get more acetylcholine? Well, I could do something like give a precursor like we saw in Parkinson's, but we don't have any good drugs to do that. What else could I do? How could I maybe prevent the breakdown? Absolutely, that's what we're actually going to be doing there. We're going to, so the main enzyme that metabolizes acetylcholine is acetylcholinesterase. If I give an inhibitor of that, then I have more acetylcholine around. Boom, you guys got it, right? So again, this makes sense if you think about it from that standpoint. Okay, well, if I can't do anything to the supply side of it, well, let me look at the breakdown side of it. And if I can inhibit that, then essentially I have more acetylcholine around. So normally what's happening here, if you can see that normally choline plus acetyl-CoA, they form together to make acetylcholine, right? And you have these neurons that are being released here. Now again, this is a synaptic cleft here, and normally once that gets activated, then it can be broken down by acetylcholinesterase, or it can be reuptaken to eventually be released again, right? Normally choline gets reuptaken here to combine with acetyl-CoA. But you're going to find that as you lose those neurons, there's less acetylcholine to be released, right? And so looking at a normal sort of functioning brain here, you can see how it would normally function. But if I'm losing these acetylcholinergic neurons, there's going to be less and less of it able to be formed there. By giving an acetylcholinesterase inhibitor and inhibiting this enzyme, I'm going to have much more acetylcholine available to interact with those receptors. And it's thought that you are trying to restore normal function, and hopefully you'll have better cognition, better memory, etc. Okay. So things we're going to focus on, there's a lot of different types of acetylcholine enzymes. There's just some different flavors of it. So some of the ones we're going to focus on here are ones that we're trying to target that are primarily in the brain, right? And so we're going to find things like having longer half-life in the plasma is also going to help to increase the duration of action. Again, the main hallmark of Alzheimer's is what? Memory impairment, right? So again, trying to remember, did I take my pill today, can become a very difficult question to answer. So again, having long-acting drugs here is going to be good from a compliance standpoint, right? Having things that are maybe patches that are going to be, need to apply once every few days or so are good things to think about. So compliance can be very, very difficult unless they have someone kind of helping them out with this. So ideally, we want something with a long duration of action, something with a high specificity for the enzymes that are just in the CNS. Because again, if they work peripherally, they're affecting all the acetylcholinesterase. What sort of side effects could you see? The dumbbells, right? So you can see a lot of secretions, defecation, urination, meiosis, bradycardia, all that good stuff. or bad stuff this case may be, right? But again, know that there's going to be a potential side effect, or going to be this cholinergic toxicity. So diarrhea is going to be a thing you can see, right? You can see things like incontinence, which again, is oftentimes what these patients may develop anyway if they don't think to, hey, I need to go to the bathroom, you go and take care of that, and that's usually what lands them in assisted living facilities, right? So little things to think about. So ideally, we like someone who's going to be centrally acting, and these are going to be useful for treating more mild to moderate cases of Alzheimer's disease. Again, we know they're not going to do anything to delay progression of disease. They're just really treating the symptoms, okay? So again, as I mentioned, there's a few different isoforms that are there. Just know that we're primarily going to be focusing on this G1 isoform because that's primarily what's up in the brain. There's other ones as well, things like butyrylcholinesterase. This one's not going to be as important to our purposes here, but primarily we're shooting for the G1 acetylcholinesterase enzyme. And so we have a couple different drugs here we can use. Tacrin we're going to find, I'll just mention it for historical purposes, but we don't use this one clinically, mainly due to the fact that you have a lot of issues with it. So one, see a lot of hepatotoxicity. That one kind of knocks it out as far as utility goes in a lot of cases anyway. But look at the dosing frequency. You're having to dose it multiple times a day. Not good for compliance from someone who has memory impairment, right? Also looking at a lot of the side effects. It's not very specific for its particular enzyme, so it's going to be affecting a lot of peripheral enzymes. You see a lot of the dumbbell symptoms. So instead, what we have are going to be a few other drugs like donepezil, rivastigmine, and galantamine. You're going to find that they have varying durations of action, varying activities, but they tend to be much better from a side effect profile and a specificity profile that they are going to be more useful for our Alzheimer's disease patients. So donepezil, relatively specific for acetylcholinesterase, especially that G1 isoform, which is nice, and it's a nice long duration of action. So plasma half-life of 70 hours. It's going to be sticking around for a while, which is good. That means it only requires once daily dosing. Perfect from a compliance standpoint, right? Also, no hepatotoxicity, very mild peripheral cholinergic side effects, so it's very nice from that standpoint. Just know, though, that you may have to worry about some drug interactions if you have any CYP3A4 inhibitors on board, maybe a 2D6 inhibitor. It could affect donepezil, but donepezil itself is not an inhibitor by any means. Okay. We have rivastigmine. This one's going to have a relatively short half-life. You know, say 1 hour, 1.5 hours. You're like, well, that can't be very useful, right? Because it's going to be out of the system very quickly. However, what it does is it actually forms a covalent bond to cholinesterase. And a covalent bond, is that easily dissolved? No, it's a pretty permanent bond there. So because of that, the dissociation is very slow from the enzyme, which means that dissociate the half-life of that is about 9 hours. So that means that it's going to have a much longer duration of action than just what the actual half-life of the drug looks like. So because of that, it's dosed twice daily. Not as convenient from a dosing compliance standpoint, but something to note there. But again, we're going to find that slow reversibility is good to help provide nice longer duration of action than what the actual biologic half-life would appear. This one's also nice because it avoids any kind of CYP drug interactions because it doesn't actually get metabolized in the liver there. So that's one benefit. If you had someone who, say, was on verapamil or diltiazem for cardiac condition, you need to put them on, say, a drug for Alzheimer's disease, this might be a good option for them, right? Because donepezil, gets metabolized by 3A4, things like verapamil are 3A4 inhibitors, right? There's a neuron back in your brain somewhere that knows that information that didn't fire there, but just if you go back and think about it, those interactions make sense. And again, when you're clinically practicing, what are you going to do? You're going to look it up, right? So anytime you're adding on a new drug, just look it up. Just even if you don't find anything, hey, it's better just to check and be safe than to go in and say, I know everything, I'm good, and then you run into an interaction, right? So galantamine or racetidine, again, this one has a moderate half-life, dosed twice daily, so not as preferable from that standpoint there. We're going to find that similar to that, the reversibility is going to be a little bit slower, so it has a longer duration than what you would normally expect. This one, although, is going to have the same interactions as you would see with donepezil, so is metabolized by 3A4, so just be aware of that. So those are the three main drugs you're going to see used from an acetylcholinesterase inhibiting standpoint. Again, know the side effects you're going to see with that, right? So again, imagine I had someone who's on donepezil and I put them on a CYP3A4 inhibitor as well. What side effects could you see from the donepezil standpoint? Defecation, urination, bradycardia, right? Those are all things bronchospasm, right? These are all things that to consider. And again, those effects are going to be more pronounced when you have something like an inhibitor on board, leading to those levels to drive up, right? So I want you to kind of think about those interactions, how they may manifest. The other side of the, oh yes, ma'am.
Do you have to worry about like renal function when it comes to these cholinesterase?
Not as much, at least with donepezil and the galantamine. You don't have to worry about it quite as much because they mainly get metabolized in the liver. I think rivastigmine I'd have to double check. I'd have to look it up. But I don't think it's something that is like as concerning as like, aminoglycoside or something like that. Yeah. Again, I don't know everything about every single one of these drugs. I look stuff up too all the time, right? It's usually half my day just looking up stuff just to be sure I know what I'm talking about when I call you guys up. Like, what's up with this order? What's going on with this? Anyway, the other side of it is focusing on glutamate, right? We know glutamate is excitatory, and so what does that normally do to the neurons in the long run? It will depolarize them, and so they're more active, and so what do you think it can do to them in the long run? Wears them out, right? So it's called excitotoxicity. So having too much excitatory input can lead to excitotoxicity, and it can eventually lead to oxidative stress. It can lead to apoptosis of the neuron. So some people feel that if you have too much excitability of these neurons due to glutamate, that leads to some of that degradation of the neurons. So if I were to say inhibit glutamate activity, then maybe I can slow down and hopefully not have as much degradation of the neurons in the long run. So this will help with some symptomatic management for these patients here. However, there maybe is a thought that it could be neuroprotective, but we don't have any evidence to really back that up right now. But it is useful for some more, say moderate to severe case of Alzheimer's disease. So memantine or Namenda is the main one that will be used here. So it's an NMDA glutamate receptor antagonist. And again, better for more moderate to severe. You may find some patients who are on both an acetylcholinesterase inhibitor plus Namenda. It just depends on the patient. Usually one will fail the acetylcholinesterase inhibitor and then switch over to the NMDA antagonist here. Again, we do see improvements in daily activities, cognitive function, etc. And it's pretty well tolerated. If you were to imagine how it's working, by having these presynaptic neurons release glutamate onto these receptors, and NMDA1 specifically, this normally allows calcium to come into the cell. And calcium normally is going to be excitatory here, and this causes that oxidative stress and eventual apoptosis. So by blocking this, hopefully you can keep that neuron around for longer to release things like acetylcholine in the hippocampus, etc. So again, nice long half-life, so you don't have to worry about dosing very frequently from that standpoint, which is nice, and it has pretty minimal drug interactions here. As you might imagine, some other things you can see include some of the CNS effects, like you may see some dizziness, some headache, but for the most part, very well tolerated. And again, we don't really know if it's neuroprotective or not. Probably assume it's not, but could have some theory there that may be somewhat useful. Okay, so any questions on that? All right, now we'll move into headaches. Yes, ma'am.
They don't really have a cure for Alzheimer's disease.
So they improve the symptoms, right? So they can maybe help with the cognitive effects, maybe a little bit better memory. The main thing you're trying to do is prevent them from having to require like a lot of home healthcare assistance, or having to go to a nursing home or things like that. You just want them to be able to kind of function, like they used to essentially. So again, we don't know if it's necessarily slowing anything down, but hopefully it can maybe prevent them from having to go into into the hospital or the assisted living facility sort of around there. Because again, usually these older patients, they do better when they're in their home environment. Like once they get out of that, they start to get, it can definitely throw them for a loop. So imagine you losing your memory, and then all of a sudden they wake up and you're in this assisted living facility. You don't recognize anyone around you anymore. It can be pretty scary and pretty difficult for them. So if we can prevent that and hopefully slow it down, then that's preferable. But yeah. Essentially, right. So again, hopefully keep them functional for longer. It's not slowing down the disease process, but hopefully keeps them functional for longer, essentially. Yeah, because we know it's a losing battle, but it's something we can try to at least deal with some of the symptoms of it. Yeah. Okay. Now I want to get into headaches, something you're all very familiar from my classes, right? The main thing I want to talk about here is migraine primarily, because this is where most of the new drugs we're going to talk about are going to come into play. I say migraines with aura. What does that mean? Yeah, you kind of know when it's coming, because you have these usually a prodromal phase where you have something like, hey, if I start to get some lights are starting to get really kind of bright, and all of a sudden sounds are kind of triggering me a little bit more. Like you kind of know it's coming, right? Some people have it with aura, some people without aura. You'll find that actually it's nice if they do have it, because if they know it's coming, they can take preventative medications beforehand. That can be sometimes useful. And then briefly we'll talk about tension headache and cluster headaches a little bit towards the end here. So getting into migraine, why do we get migraines? Because you have pharmacology at 8 o'clock in the morning on Friday. Could be a good one. Well, essentially what we think is happening here is that part of the process is going to be when we know it's originating within the brain itself. The main thing we're going to see, though, is you get this kind of this vasodilation that occurs here, some of these cerebral blood vessels, right? So again, you're going to find some changes in where they're going to get more vasodilated. It's going to allow more blood to flow in. What's that going to do to pressure, do you think? It increases the pressure, right? Because again, you get more blood flowing in there, it's kind of filling up more space in there. And that can do things like put pressure on things like the trigeminal nerve. Put pressure on some of these nerves there. When you activate those nerves, What does that induce? It induces pain, induces some of that light sensitivity, the photophobia, phonophobia, all those sorts of things you're going to experience with migraines here. And so the main thing we're going to be focusing on as far as drug therapy goes is to try and squeeze down those blood vessels to decrease that pressure and relieve that activation of those nerves. That's the main thing we're going to find. That's going to be good for acute abortive treatment. When I say abortive treatment, it means you're aborting out of, kind of like you hitting the abort button, like get out of this migraine now. We're talking about abortive treatment, which is good for acute migraines, and then we'll also talk about things that will be useful for helping to prevent the migraines from occurring. Okay, so it's good to know which ones are doing what, and that will probably come up as a test question at some point. You know, which ones are good for prevention of migraines versus which ones are good for acute treatment of migraines. It's important to know the difference, because what can happen if I have too much vasoconstriction here in these cerebral vessels? You get stroke out, you get ischemic stroke. Not usually an ideal thing for most of your patients. So these drugs are definitely dangerous in that standpoint. It's important to know when you can use them, how often to use them, etc. Because, again, migraines can be debilitating for a lot of patients. Imagine if you had a migraine, you can't get out of bed, but you have to go to sit in class for 8 hours a day. That can be really tough, right? So we want to be able to treat that, but need to balance it out with the side effects of the medication, because we know there are certainly some side effects there. Things that are going to be good for the chronic management to try to prevent them are usually going to be focusing more here on this sort of this spreading wave of depolarization that occurs here. By blocking that, and this is where you see some of our antiepileptics will come into play, they can hopefully help prevent that migraine from occurring in the first place. So as I mentioned, like Topamax is going to come up in here. You may say valproic acid could be used potentially. We'll talk about those a little bit later on. Okay. So anyway, so our goals, one, we'd like to reduce the number of episodes, the frequency, the duration, all the good stuff if best we can, and hopefully improve quality of life, right? That's always going to be the main thing here. For the acute migraine, that we need to look at our abortive therapy and things we're going to be able to use to treat migraine very quickly. What do people normally get in addition to the migraine? You get the pain, the photophobia, what else is going to go along with that? A lot of nausea and vomiting, right? So we're going to find that antiemetics are also very useful in conjunction with migraine treatment. And so oftentimes we're going to usually get a good cocktail of several drugs together in order to help treat that acute migraine. We'll talk about that in a minute. Okay, so we'll look at non-pharm therapy, OTC therapy, and then prescription therapy as far as our different treatment options. Obviously, which one's going to be most effective here? Probably our prescription drugs, right? Listen, for some things, you're right. Non-pharm therapy is the way to go. This is one of those cases there where you need some drugs. I don't know if you ever had a migraine before. I have not personally, but sometimes you just need drugs, right? So this is one of those cases there. Anyway, so as far as like non-pharm therapy, you can do things like avoid triggers, obviously. If there's certain smells or certain things that'll trigger you off, try to avoid those. If it's a particular class, sometimes you might be out of luck and you just have to sit through it anyway. You know, it's just how it is. But, you know, things like stress management, you know, things like relaxation training, all this stuff can be somewhat useful. Now, as far as triggers go, again, you can find things like, you know, alcohol withdrawal in some cases, caffeine withdrawal. I'm sure if any of you went cold turkey off of caffeine, there's going to be a heck of a lot of headaches going around here. But remember, what does caffeine normally do to the blood vessels? Is it vasoconstrictive, dilatory? It actually vasoconstricts, right? Because again, you think you get too much caffeine, you get hypertensive, right? Same thing's happening here. So if I were to lose that and those vessels all of a sudden dilate out, that's what we said was causing the migraine, right? So again, you think about these things, it makes sense from a mechanistic standpoint. The other things, you know, high altitude, strong smells, flickering lights, any of those things could be potential triggers here. And it's good to know what those are, so that way the patient can hopefully avoid them if possible. So as I mentioned, the pharmacologic therapy can either be acute or it can be for preventative therapy, so it's good to know which ones fall into which categories. And again, it should be based on how they're presenting, signs and symptoms, the frequency, duration, etc. And again, I'm going quick. I'm trying to hopefully get through as much of this as I can. Again, we'll have time, hopefully, for questions at the end. But anyway, so general principles here. We want to administer medications at the onset of the headache. If they have an aura beforehand, that's perfect, because then you can treat it before the headache actually starts. That can always be a good thing. A lot of people don't have an aura, so you can't necessarily do that. You'll find that the medications don't do anything for the aura itself. So if they're going to have an aura, they're just going to have it. You just know that. But again, if it can hopefully abort the migraine before it starts, it's always going to be a good idea from that standpoint. And typically, we like to have no more than 2 times per week we're using these abortive therapies. Why do you think that is? You get a lot of rebound headaches. It's called medication overuse headache, where basically by using these medications too frequently, you're going to find that as you stop using them, one, they get less effective as time goes on, and then you get a lot of rebound headaches and you're not using them all the time. Okay, so again, the ideal thing we like to do is to use a combination of preventative therapy along with this acute treatment, so that way they don't need more than 2 times per week. Hopefully 0 times per week would be ideal, right? And so a lot of times they'll have prescriptions for, say, preventative therapy they're going to take scheduled around the clock every day, and then they'll have abortive treatment they'll have as an as needed sort of basis. Okay. So So let's look at acute treatment. We have for mild to moderate migraines, obviously we can start off with the easy stuff. So things they can get over the counter. This is very frequently why I like to ask patients when they come in for migraine, what have you already taken, right? Because usually they probably tried something themselves, it didn't work, and now they're coming in. This is very, very important, especially not only for the over-the-counter stuff like NSAIDs, aspirin, Tylenol they may be taking beforehand, but also if they have known history of migraines and they take prescription-based products, what are they taking there? Because it may preclude me from giving anything else, or what type of drugs I can actually give. Okay, just kind of keep that in the back of your mind. So certainly, you know, acetaminophen, do you think it's going to be useful for a true blue migraine? Nah, it's going to be like, you know, using a little pea shooter to try to take on a tank or something like that, right? It's not going to do anything, right? But NSAIDs can be somewhat useful, right? So things like naproxen, ibuprofen, aspirin, any of those can have some utility there. And again, one of the things that they may get in that cocktail as they come in, say, for instance, to the ER, the urgent care clinic, is an NSAID. You may give them a dose of Toradol. However, if they just got ibuprofen 2 hours ago, I'm less likely to give them that drug because I worry about toxicity from those two, right? GI toxicity, renal toxicity, etc. So again, ask them how long ago they took the medications. If it's been 12 hours, okay, they can probably get another dose of an NSAID at that point, right? So think about the durations of action of these drugs here. But generally, Toradol is a good one because you can give it intramuscularly or IV. And again, it's nice because it's a little bit more heavy duty, get into the system very quickly, can be very, very effective from that standpoint. Generally, we do not use opioids for treatment of migraines because again, it doesn't fix the underlying problem. It really has no role to play for treatment of migraines. Okay, just note that. Nausea and vomiting, how do we treat that? Well, some different things we can try. One, we have our phenothiazines. You can use things like promethazine, difenergan can be useful. If they're actively vomiting, this is where suppositories can be somewhat useful as well, occasionally. Things like metoclopramide, prochlorperazine. A lot of my docs just love to use compazine, which is prochlorperazine, along with some of these other abortive treatments. That's just their cocktail. They grew up learning how to use that. But there's nothing to say that things like Zofran are not going to be effective here, right? Zofran works just as well. And again, this is useful because one of the other things you're going to find with the abortive medications we're going to talk about in a second, they also cause a lot of nausea and vomiting. So you want to typically pre-treat with at least one of these. One of the other nice things you're going to find is that if you have a migraine, you're able to sleep very well. Not usually, right? So the nice thing about using a phenothiazine is what? Cause some sedation, right? So like, man, I couldn't sleep all night, just making the migraine worse. Give them some promethazine, you're gonna sleep very well, right? May even fall asleep on you right in the middle of the ER. Okay. And whenever been like in the middle of like a busy ER, the cacophony going on at all times, but somehow people sleep. It's usually drug induced, as you'll find, right? Either from us or from them themselves coming in. Anyway. So again, we're going to cover, we already talked about those in the GI section, so you guys know the side effects commonly you're going to see with these medications. It's something like Zofran, what are you worried about? QT prolongation, otherwise don't have to worry about too much with it. But again, certainly the phenothiazines, you have to worry about things like EPS it can develop with really high doses, sedation, etc. Right? So for more moderate to severe migraines, this is where we're going to get into our abortive treatment. This is where we're going to find their ergots are going to come into play. So just like we talked about for treatment in Parkinson's are coming back. And then we also are going to have our triptans. They're going to have a little bit different mechanisms we're going to see here. But basically, ergots, these are going to be your vasoconstrictors, which makes sense based off the pathophysiology we mentioned. You had that cerebral vasodilation. So by constricting down those vessels, you're going to find that's going to help to relieve that pressure. Okay. Also, LSD, anyone know what that is? Lysergic acid diethylamide. It's a hallucinogen. So also one of the things that people are getting when they're eating that infected bread, they're also getting hallucinations and stuff too, right? So it actually is a derivative thereof, and so again, it's in the same family. These drugs are not going to cause you to have a groovy trip by any means, but just know that they're in the same sort of structural family, essentially. But anyway, so we have a couple of different products here. We have things like ergotamine tartrate or Ergomar. This is either oral or has a suppository form, good for patients who are vomiting. The one I see most frequently is dihydroergotamine or DHE. You see DHE, that's what we're referring to. Migranol is the brand name. This one's nice because it either has a nasal spray, good for patients who are vomiting, or it has a parenteral form as well, which is what we use most often in the hospital there. That is the IV form. These are working by causing constriction of the vessels by activating 5-HT1D and 1B receptors. 5-HT is another name for what? Serotonin. So these are activating serotonin receptors, 1B and 1D are what they're activating here. That will cause cerebral vasodilation or constriction. It will relieve that pressure and then hopefully abort that migraine. Okay. You do some other things as well with causing some decreasing some inflammation, decreasing some of the vasodilatory effects. But the main thing it's doing is activating that vasoconstriction. Okay. So looking at this, you're going to find that nice thing about ergots is they have a pretty decent long duration of action here, which is nice because it helps to decrease the recurrence of migraines. You don't want to have something where you treat a patient in the ER, they go home, and they all of a sudden have a rebound migraine because the drug basically wore off too early. And so in this case, this is why we like the ergots there. However, there's a lot of side effects associated with this. Does it just constrict vessels in the brain? No, it's going to constrict vessels elsewhere as well. So you can see things like chest pain. You can see things like peripheral ischemia that can develop. You can see things like numbing, tingling sort of pains. Notice this is a lot like what I talked about in that St. Anthony's fire, right? So again, the bigger the doses you're giving, the more repeated doses, the more likely you are to see a lot of these side effects. Does that mean can you induce an MI? Potentially, right? If you had a really high-risk cardiac patient, yeah, you could probably cause an MI in these patients, right? It can cause bowel ischemia, brain ischemia, so be really careful. Ask about what they already used at home. If they already used DHE at home because they had the nasal spray, because they have recurrent migraines, and they come in, I don't want to give them another dose because otherwise I can induce a lot of these vasoconstrictive side effects. Okay, so just kind of keep those things in mind. You have to know what they already took because chances are they probably have a history of migraines and they probably have taken something already. Okay, so who to not use this in? One, you don't want to use this with anyone with vascular coronary disease. You don't want to use this in patients who have untreated hypertension. Now, again, if I have a patient who has hypertension, it's well controlled, say lisinopril and hydrochlorothiazide, and they come in and their BP is 130 over 85, am I going to treat that patient? Yeah, I'd probably give it to them. It's probably not too bad. If they come in, they're 180 over 100. I don't want to do that, right? It's just playing with fire at that point, right? You don't want to do that. So again, take it as a relative contraindication, okay? Because again, migraines cause a lot of pain. What does that do to your blood pressure? Probably increases a little bit anyway, right? So you can think about why they're hypertensive in the first place, right? Think about what their baseline is, what their normal is, and then consider where they're at right now based off of that, okay? Other things to consider: pregnancy. This is a category X drug. We'll talk about pregnancy categories briefly in the OB/GYN section later on. But you cannot give this to pregnant women. Also, who's more likely to have migraines? Young women with childbearing potential. What do you got to check before you give this? Got to check a pregnancy test. They come in and say, there's no way I'm pregnant. You trust them? You're still going to check it, right? Just pee in this cup real quick. Just find out, to be sure.
Is this contraindicated to take with contraception though? I know there's some migraine medications.
This one, not necessary. Now, one thing you could consider is that a big risk for using oral contraceptives are risk of thromboembolism. Because they actually work in the liver to increase clotting factor production, so you can see risk of clots there. If you had a clot on top of this vasoconstriction, that could lead to further occlusion, could lead to things like PE, things like that. So that might be a relative contraindication, but I've seen patients who have taken both at the same time. I will tell you the ergots are not used as frequently as the triptans are nowadays. I'm just mentioning this because you'll still use it for more treatment-resistant patients, and plus it's been around for a lot longer. So I kind of mentioned this one first. That may be a relative contraindication. Other things as well is you do not want to use this within 24 hours of a triptan. Okay, triptans are the next set of drugs we're going to talk about here, but you don't want to use them together because they could cause synergistic vasoconstriction, could lead to stroke. Right? You don't want to have that happen. So getting into the triptans, these are also going to be 5-HT1D and 1B agonists. They tend to be a little bit more specific for those receptors. So you're not going to find the same sort of kind of wide-ranging effects as the ergots. They can still cause some chest pain. They can still cause some vasoconstriction, especially really high doses. But they tend to have a little bit better side effect profile. And so again, you can tell it's a triptan because we'll have triptan at the end of the name. So the first one we have is Imitrex or sumatriptan. Notice here's a lot of different dosage forms that are available. We have things like nasal forms, we have subcutaneous, we have oral. Very nice from that standpoint because again, they're vomiting a lot. They're migraines. They'll give them the intranasal form, right? Sub-Q we can give in the hospital setting, things like that. You don't have to memorize which ones come in which dosage forms. I just want you to know that the reason why we have so many different ones is usually due to the fact that oral route may not be good for a lot of those patients based off the nausea and vomiting. The main differences between a lot of these are going to be basically the duration of action. So obviously longer duration of action usually means you're going to have less likely to have recurrence of migraines. They usually are also going to be slower in onset, so they may not work as quickly for those patients who are coming in, right? Those are all things to consider there. So we'll talk about these more in detail in just a second. So as I mentioned, they're working almost the exact same way as the ergots. They're going to be activating 1D and 1B receptors to cause vasoconstriction on the cerebral vessels to decrease that pressure. Okay, could be some presynaptic effects where it works on inflammation, but the main thing it's doing is that vasoconstriction there. Okay, as I mentioned, very effective in the majority of patients who are receiving this. However, especially like sumatriptan, because that was the first one that came out, you did see a 40% recurrence during the same day. It's not ideal, but by using some of the ones that have longer durations of action, something like frovatriptan or Emerge, you actually find they have less recurrence there. So if you know they have a history of recurrence, this is where you can use something like one of these other ones that have a longer half-life, and that will decrease that chance for recurrence. A lot of people do just fine with sumatriptan by itself, so they don't necessarily need to jump to one of these other ones, but if you know they have that history, maybe something to consider. So, as I mentioned, a lot of patients are going to have some side effects with this, especially if they're getting any kind of parenteral administration. You're more likely to see these effects because, again, that dose is getting in there immediately. So you can see things like chest tightness, pressure, pain. Again, that will dissipate with time. Certainly you can see some other things like paresthesia, asthenia, but again, those are usually going to be transient, not usually as severe as the ergots would be. Okay. As far as contraindications go, ideally you wouldn't want to have to use this in pregnant patients, but it's not going to be as teratogenic as something like the ergot alkaloids would be. Okay. We'll talk about pregnancy-related headaches and things like that a little bit later on. What we prefer there, because ideally, what's the best drug treatment for pregnant women? No drugs, right? No drugs. Sometimes no drugs is the right answer too. That's always preferred. Well, yeah, we'll talk about things that are some safety profile things. But anyway, so again, you have to be careful here. You would not want to use this in patients with a history of MI, angina, cerebral vascular disease, monoamine oxidase inhibitors. Why is that, do you think? Just increasing, risk for serotonin syndrome could increase risk for vasoconstriction, hypertension, right? So again, think about that. And again, no use within 24 hours of ergots. Yes, sir.
So let's say if we have to give a drug for headaches, which one is safer, or category B or C, which they can take in pregnancy?
Oh, we'll talk about that in a little bit. Just you wait. I have a whole section on that. Yeah, not yet, but I'll get there eventually. Yeah. If not here, then I'll get to it in the OB-GYN section later on. So yeah, I don't want to overload you too much. Well, more so than I normally do. But so anyway, so again, usually sumatriptan is the gold standard because it was the first one we have out. We have the most experience with it. It's also the cheapest out of the bunch, so that's why we like to go with that one, generally first line. Just know that some patients are going to have recurrence. If they do, then you can consider switching to something else. Again, depending on the dosage form, you're going to find that the onset's going to be a little different. So obviously, which one do you think would be slowest? Probably oral. A little faster than that would be intranasal, and then faster than that would be sub-Q IV, right? So again, you guys understand the kinetics there, so you know why that would have a faster onset, okay? But generally within an hour for the sub-Q form should have pretty good efficacy, usually within 2 hours of the intranasal or PO forms. So other agents we have, the second generation agents are going to be designed really to help either increase bioavailability of the drug to get it bypass that first pass effect a little bit more, or to decrease that recurrence rate and hopefully help with the side effect profile there. So typically they're a little bit more potent, a little bit more lipophilic. They can get across that blood-brain barrier a little more easily, and they usually have an improved kinetic profiles, longer half-life, better bioavailability. So zolmitriptan, narotryptan, these are both good agents as well. Usually you're going to have similar efficacy to sumatriptan. You just might find that with the longer half-life, they're going to have less recurrence rates you're going to see with that. So for instance, and again, some of these come as an ODT or an oral disintegrating tablet. Some come as a nasal spray. Just know there's different dosage forms to try to get around the PO route if they're having active nausea and vomiting. Again, something like narotryptan has a longer half-life than sumatriptan does, but has a slower onset. So, within 4 hours or so. And again, if you have a migraine, do you want to wait around 4 hours for that to kick in? Not really, right? So again, maybe something where if they have history of aura and they know that a migraine's coming, this might be a good agent to take there because, okay, by the time that 4 hours hits, the migraine will start to kick up and then maybe I prevent it altogether. Little things to think about. Rizatriptan or Maxalt. This one is interesting because actually when you give it with propranolol, you actually see a big increase in the AUC, or the area under the curve, which is basically a measure of how much drug exposure a patient has. Now you may be asking, why would a patient with migraines take propranolol? We're actually going to find this is a good preventative therapy. So you just have to know that you have to decrease your initial dose of rizatriptan when mixing it with propranolol. Okay. Otherwise, you're going to see levels rise too high, get that chest tightness, get the hypertension potentially, see some issues with that. Okay. But it does have the fastest onset of all the PO triptan, so they have no aura. And once they get it, like they know it's coming on. Once it happens, it happens. Like this is a good agent because it's going to have faster onset. Okay. A couple more. You have elatriptan, elmatriptan, frovatriptan. Frova is nice because it has the longest half-life of them all, so if they have a lot of recurrence rates, then this is going to be a better agent for them overall. Elatriptan is a CYP3A4 substrate, so you have to worry about drug interactions there. and along with amitriptyline as well, you do need to worry about those interactions, right? But again, really at this point, any of them are going to be fine. Usually it's one of those Me Too kind of class of drugs. So when the sumatriptan came out, a lot of different companies said, well, let's go ahead and make our own version as well. So that's why you see so many different types. So again, once you're working with these patients, you'll kind of get a feel for which ones, you know, are going to be your go-to. But typically sumatriptan is going to be the first line one. So, again, these are good for patients who are not responding well to, say, to NSAIDs or if they have really severe migraines. This is where you want to start off with your triptans. Ideally, you can use the non-oral route for early or maybe significant nausea and vomiting. This is going to be good cases for an intranasal form or like an ODT form, something like that. And typically for sub-Q, at least give it an hour to kick in. Intranasal PO forms, give it at least 2 hours before you see when the efficacy is really starting to go. And you got to let your patients know, hey, this doesn't kick in immediately. Just because you inject yourself or do an intranasal spray, it's going to take a little bit of time. And again, typically we do not want to use triptans within 24 hours of ergots or other triptans. So they say, hey, I took sumatriptan at home. You can't give them forovatriptan in the ER because with that 24-hour period, because again, you see too much vasoconstriction there. So that time frame is very important there. And again, we try to avoid exceeding 2 days per week. Otherwise, you start to run into that medication overuse headache sort of phenomenon. So, and again, typically looking at this, and we're not going to have time to get into the preventative therapy here, but typically, as I mentioned, triptans are going to be your first go-to agents, sumatriptan typically. If they're not good responders to that, that's when DHE or their other ergots can be used as a backup, right? Those typically for patients who have failed triptan therapy initially, okay? And again, look at the contraindications a patient may have, right? Think about things like pregnancy for their ergots, right? Think about checking for UCG beforehand, things like that. When I say UCG, anyone know what that stands for? Urine chorionic gonadotropin, right? So again, it's usually what the blastocyst, the baby's starting to produce there, right? So that's how we, or you may see like a urine HCG, UHCG, you might see that as well. Human chorionic gonadotropin, right? So those are things we're measuring to see if a patient's pregnant or not. Because again, patient may be pregnant for quite some time before they even realize it, right? Right up until they actually deliver the baby in some cases. I don't know if you've seen just TLC shows, but it's pretty crazy. I had no idea. Like I said, with my second one, we didn't know until we were just like, you seem like you're in a really kind of crummy mood and you're really nauseous. Are you pregnant? And I guess we'll check. And sure enough, there we go. Anyway, so again, if you have more mild to moderate symptoms, start off with the OTC stuff, or early. Start off with the easy stuff. If it's more severe, that's when they need to start thinking about beefing it up to go with one of these serotonin 1D, 1B agonists there. That's usually going to be your backup. And again, using multimodal therapy is going to be very useful here. So if I have a patient coming in to the ER for an acute migraine and haven't received anything yet, we're probably going to hit them with Toradol, right? From an NSAID standpoint, help with inflammation. We're probably going to hit them with Compazine as an muscarinic, antiemetic sort of drug to try to help them maybe kind of sedate them a little bit. Probably going to hit them with sumatriptan and probably a liter of fluid to go along with it, right? So that way you can get this nice multimodal therapy. Everyone feels better with a liter of normazoline in them, right? It's a great drug, great drug. Hey, for me, I really need my Dilaudid. Let me try giving them some normazoline first and see how that works, right? But yeah, so usually you'll get that kind of cocktail and it usually helps out. Patients feel a lot better afterwards. Okay, so that's all I'm going to cover for today. I know I don't have too much longer, but the quiz will go up through this part of the section here. So I think it's behavioral, after depression meds, up through this. Okay, so kind of go back to your syllabus and you'll know what we're covering for the quiz in 2 weeks' time. So you have a lot of time to study for it. Let me